Okay, so I've divided the lecture slides into two parts having to do with the two chapters we'll be reviewing, more or less, and then if we have time for the fourth part, it'll be an activity. And so let's talk about psychopharmacology and more generally about brain chemistry next. We'll be talking a lot more about psychopharmacology in the sense of brain chemicals and how they are affected by drugs in future lectures as we talk about the diseases that are involved. But I want to give you a kind of a primer or review, hopefully still a little bit at this point of the course on brain chemistry, because that'll be an important context alongside the gross and fine structure of the brain as we talk about the effects of drugs, the disorder processes in different brain disorders and so forth. Okay, so without further ado, this is following along with chapter 4 in the textbook. So far we've been studying the structure of the nervous system, how neurons operate and how they are arranged into units. Psychopharmacology looks at how chemical processes affect neurons and enable or interfere with their functions. And so to some extent we're kind of switching from the structure to the function. We're talking about processes and now how the brain actually gets things done. And these two things are important in context. If you look at the history of lesional models of the brain's clearly not organized into discrete structures that explain cognitive skills in and of themselves, in the sense that there isn't a memory structure in the brain that handles the whole memory process. The memory process is subsumed by networks that connect various structures, and those networks involve chemical interchanges. So chemicals, be they endogenous, meaning they came from inside the brain, or exogenous, meaning they were introduced from outside of the body, act on one or more specific sites of action in the brain, particularly as ligands and receptor binding sites on neurons, but potentially also on glia and other cells, like we talked about purinergic signaling really briefly, I think in the first lecture, and there the receptor binding sites were on the glia or astrocyte, and not on the neuron itself. So, drug action and evolution. We're interested in two specific processes, and I think the book uses this term but not this term. These terms are often discussed in conjunction, and so you should know them both. Pharmacokinetics is what the body does to the drug, and in particular things like metabolization. And at a really basic level, in contrast, pharmacodynamics is what the drug does to the body. For instance, blocking serotonin reuptake. So what the body does to the drug and what the drug does to the body, it's a reciprocal relationship, and we are interested in both of them. With respect to pharmacokinetics, the book talks in more detail about different routes of administering medications or drugs to the body and the different uptake rates. What I want to draw your attention to is a general principle, which is that the very fast routes, like intravenous exposure, involve a very rapid increase to a high peak concentration and also a rapid decline over time. So if you look at some of these other routes, they provide slower and steadier availability of medication in comparison, say, to IV administration. You might compare that to our discussion just a few minutes ago of ionotropic and metabotropic receptors. Conceptually, in the same way, there are routes that allow for very rapid availability of a drug, and there are routes that allow for long-term availability of a drug. So I just provide some examples of where these different things would be relevant. Obviously, this particular graph is talking about some things that have to do more with drugs of abuse, since there aren't a lot of medications that you use via smoking, although marijuana is recognized as a medication that you smoke. But if we talk about on the medication side, intravenous, a good example of when drugs are used intravenously is in the hospital, right? So haloperidol or Haldol is not really commonly used as an antipsychotic in an outpatient setting anymore because it has too many side effects, but it is sometimes injected intravenously in the hospital to solve acute aggression or behavioral disturbance. Similarly, benzodiazepine or anti-anxiety medications like Ativan are used intravenously in hospitals. So for instance, Ativan will be used intravenously in a hospital to stop a seizure when necessary. So for example, status epilepticus means a seizure that doesn't stop, and that's a medical emergency, and you'd want to stop it with something like Ativan that's injected intravenously, and their rapid on-take is really important. Not to mention if someone's having a generalized seizure that doesn't stop, they're not going to be able to swallow a pill anyways. So those are some times when intravenous injections are really important due to this rapid uptake. There are other times when intravenous injections are ongoing, like a morphine drip or something like that, so that the medication is available over the long term. But drugs that go in via this route go very quickly. You look in comparison to the oral administration in the blue, and you see that it's a slower, more gradual curve in comparison. There are some drugs that are used in very long time scales, like via patch transdermal administration. Can anyone think of any examples of that? There are a handful that come to mind more readily. A couple that have to do with this kind of classes and the This is a really good example. Yeah, birth controls are prescribed in that kind of way. There's also the implanted birth control, where it's put in a capsule. The book mentions this kind of administration route. The capsule's put in underneath your skin, and it dissolves very slowly. That's really nice because you don't have to worry about adherence to the medication. You don't have to worry about missing doses and things like that. Couple other examples. There are patches used for nicotine administration for smoking cessation. There are patches used in a couple other situations where adherence is a much bigger issue. Most women of childbearing age are able to take medications on a regular basis. But you think, for instance, about people with dementia, there are patches for some of the anti-dementia medications, and their regularity of administration can be a real big issue. So I think there are patches that are good for both Parkinsonian symptoms and also Alzheimer's symptoms. And so those are long-term administration as well. Enough about that. With respect to pharmacokinetics, some people talk about this, oftentimes they say ADME kind of is the mnemonic to remember, although liberation is also important. These are 5 processes that affect pharmacokinetics. How quickly you absorb the medication, how quickly the medication is liberated, like from a binder. And so oftentimes you'll talk about extended release medications, where the binder in the capsule is designed in such a way that there's a slow release or availability for liberation of the medication. Distribution, how fast does the medication get from being liberated to being bioavailable in the tissue of interest? So for instance, for psychopharmaceuticals, how quickly does it get to the brain, right? So lipid solubility is a big factor to be aware of here. Highly lipid soluble chemicals will bind up in lipids and pass through the blood-brain barrier easily. And that leads to faster bioavailability compared to drugs that do not lipid develop. Metabolism is also important. Metabolism by the liver. And not all medications are metabolized by the liver. That's something to be aware of. But this is going to be affected by any condition that affects the liver. So if a person has hepatic failure or insufficiency, generally speaking, what that means is that the liver is not good at metabolizing things. And so generally what that means is that there is going to be more of the drug available in the blood because the liver is not removing it from bioavailability. One point to be aware of in passing here is there's a cytochrome system called the P450 system, or CYP450. You may have heard this term before. This is a family of liver metabolism processes that actually is responsible for metabolization of many pharmaceuticals. And so there are, I think, 8 or 9 of these, I forget how many. But the reason I'm bringing this up is multiple pharmaceuticals, for someone who has polypharmacy or taking many medications at once, multiple pharmaceuticals that load on the same cytochrome 450 mechanism will interact with each other in the sense that they're sort of getting in the way of each other being metabolized by the system, meaning, again, that there'll be more of the drug available. And some things other than drugs are also metabolized this way. Grapefruit juice is a real common example. And so certain anti-seizure drugs in particular are potentiated or made more strong by grapefruit juice in the system, because again, the grapefruit juice is blocking metabolism of the drug. And in principle, I guess that could be good in the sense that you can take less of the drug and get the same effect. It's bad if it's not being accounted for, though, For instance, you could have a lot more of a drug in your system on the days you drink grapefruit juice than when you don't. That could lead to withdrawal effects for some drugs. It could lead to instability and availability. If you're looking at availability on days when you drink grapefruit juice, it looks higher than it really is, meaning on many days you actually have less drug available to you. So you want to take these things into account. And so it's really common for people who take certain drugs in these classes to get counseling on nutritional impacts. And then finally, excretion by the kidneys. And so the liver converts drugs typically into a non-pharmacologically active form, although there are some drugs where the metabolite is active. That's when the thing that the liver converts the drug into is still bio-useful. That's called an active metabolite. We've maybe briefly talked about one active metabolite. Can anyone think of an example of that? So the example of that we really briefly touched on has to do with dopamine. So again, you can't put dopamine into the blood because it won't get to the brain, but you can put a precursor into the blood, and then the metabolite will get into the brain. Some drugs are not metabolized by the liver, and they're directly renally excreted. So this may be an important consideration for someone who has liver compromise, for instance, going with a drug that's directly renally excreted. And sometimes you can also balance, for instance, PSY430 loading by using drugs that are renally excreted. But ultimately, the drugs have to leave the system, and the kidneys are responsible for that. So drug effectiveness, again, depends on both the kinetics and the dynamics, both on what the body does to the drug and what the drug does to the body. Many drugs have multiple sites of action with varying affinity at each site of action. And so things start to get really complicated really quickly, right? A really good example of this is the modern antipsychotics. I think the book has some picture examples where many of the antipsychotics have 8, 10 different binding sites that bind in different places and do different things. And many times we don't really even understand, to be frank, what they do because they do so many different things and we're not clear on how they work. And all of these effects are contributing both potentially to desirable effects of a drug, and sometimes there are primary and secondary desirable effects. An example of that would be that antipsychotics obviously will result in psychosis. Many of them have a side effect of weight gain, which for most people is a big problem. Occasionally in eating disorders clinics, psychiatrists will be sneaky and administer Zyprexa in small doses to stimulate the appetite. Typically that'll work until the teenager who has a normal IQ figures out why they're being prescribed Zyprexa, and they won't take it anymore. But so that potentially arguably could be a positive impact in that case. And then it's also important to know that many drugs with similar functions can have different mechanisms. So for instance, there are 15 drugs that are used for epilepsy. They fall into 2 major categories. Some of them are GABA agonists and some of them are glutamate antagonists. But then some of them do both of those things. Some of them do neither and yet appear to help with seizures. So there can be different mechanisms for drugs that seem to cause the same effect. Similarly, Celexa and Prozac and all those drugs are serotonin reuptake inhibitors that resolve depression, but they're also drugs that don't affect serotonin, like norepinephrine reuptake inhibitors that affect depression. And so there can be different underlying mechanisms that have an all roads lead to Rome kind of effect where even though the mechanism is different, the outcome is the same. The book shows you this picture of a dose-response curve. This is an important concept. For most drugs, there's some loosely S-shaped relationship between dose and response. Although what differs from drug to drug is the slope here. Some drugs essentially have a step function. Some drugs have progressive response. And so, for instance, I'm trying to think, for most people, there's a progressive response to alcohol, for instance, meaning you get drunker and drunker as you drink more and more. The anxiety medications, a lot of them have progressive responses. If you're taking seizure medications to quell seizures, it's more of a step function. You either have enough of it in your body to get rid of the seizures or you don't. And so the slope of this can be different. And so for many drugs, at some point you reach a point where there's no longer an effect. Related to this is this graph that's also in the book. And here, it raises the point that there may be multiple dose response curves for different aspects of response to a medication. And the analgesic effect, in this case of morphine, is a positive response. The depressive effect of morphine on respiration is a negative response. Hopefully, you get negative responses at higher doses than positive responses, because otherwise you're kind of in big trouble if these are reversed, right? Because you're getting toxicity before you're getting effectiveness. So the orange curve should be to the left of the blue curve. The margin of safety is how much room you have to play around. We talked about factors that change bioavailability, like drinking grapefruit juice for certain medications. So there's also things like how adherent are you? Maybe you take your medication an hour later or an hour earlier. These are all going to have small effects on where you sit on this curve. And you want to know how far you are away from toxic effects. A very safe drug has a very large margin of safety, meaning you don't need very much at all to benefit from it. You need a lot to really have harm from it. So for example, in depression, the early depression drugs like the Mayo inhibitors had a fairly significant margin of safety issue, and they were, for instance, drugs that you could overdose on and die. In contrast, the SSRIs like Zoloft and Prozac have a relatively large margin of safety. This has some real practical epidemiological considerations. Mostly, people in the old days were referred to psychiatrists for management of these high-risk drugs. But typically now, many other kinds of healthcare practitioners will prescribe SSRIs because they're much safer, right? And so you see SSRIs being prescribed really commonly by primary care physicians and pediatricians, not uncommonly by OBGYNs and other practitioners, and in large part because they can treat depression safely. And that's important because depression is highly common. We don't really have enough psychiatrists to send every person who needs to be treated for depression to a psychiatrist. On the other hand, it could potentially also introduce a problem effect. With these high margin of safety medications, there's more potential for over-medication because there are more practitioners doing it. So some people argue that happens with SSRIs. Some people argue it happens with stimulants for ADHD, because those are, again, a fairly safe drug. The response to the drug can also undergo experience-dependent change, meaning that over time, how much medication you need to have a response and or an adverse response, more either positive or adverse, can change. And so tolerance and withdrawal and sensitization are very important concepts in that context. So for instance, tolerance and withdrawal are related effects. As the body accommodates the presence of a drug, larger doses are required for similar effect, particularly for similar positive effects. And you start to see negative effects in the absence of the drug. A really important concept here is that withdrawal symptoms are typically the opposite of the drug effect. A really good example to help remember this is if you think about alcohol. If you've ever drank it, don't answer that question if you're not 21. Alcohol makes you calm, typically, right? It's a social libation. It makes you more sociable. It makes you feel more at ease, less anxious, all those kinds of things, happy, with at least in small quantities, right? So in large quantities, it actually has a different effect, typically. But in small quantities, it makes you feel good. It makes you feel sleepy, too, typically, right? There are lots of people who'll drink several glasses of wine late at night because they don't sleep well. But if alcohol makes you sleepy, then withdrawal from alcohol will make you alert. And that's a problem because you're withdrawing from alcohol while you're asleep, right? And so you'll hear this problem really commonly in insomnia populations. They drink 3 or 4 glasses of wine to fall asleep. They fall asleep and then they wake up at 2 in the morning and they can't fall back asleep because they're going through alcohol withdrawal at 2 in the morning. And so that general concept applies to other drugs. Drugs that have a short time scale, like fast-acting drugs, are going to be more prone to these behavioral effects like tolerancing and dependence. And so, for instance, as a real concern with anxiolytic drugs like benzodiazepines like Xanax, you take it and you feel better, right, from your anxiety for a couple hours. And then you start to feel worse again. And so what do? You take another Xanax tablet and you feel better again, but then a few hours later you feel worse again. Doesn't really solve the problem. If people need more than brief treatment for anxiety, we usually recommend that either they're on a medication that's not short-acting, like an SSRI, or they're in something else like psychotherapy that can resolve the problem. And then if they need to be on something like a benzodiazepine, it at least has to be a long-acting benzodiazepine, not one with a half-life of an hour, but a half-life of a day or something like that. That reduces the behavioral dependence. As the book mentions, so sensitization is the opposite of tolerance, meaning instead of the effect becoming less significant over time, it becomes more significant over time with the same dose. There are times when that happens. I'm trying to think of good examples. It happens with certain drugs of abuse. There are some drugs where there's sort of some kind of change process that occurs, and so you can have a stronger response to smaller doses after you've been primed by it. A real common example of sensitization that doesn't have to do with pharmacology is in epilepsy there's a kindling model, and that kindling model is applied to other neurological disorders. And if you've ever heard the phrase seizures beget seizures, recently people in the migraine world have stolen that, and they've been saying migraines beget migraines. The idea is that there's a sensitization to that neurological phenomenon. After you've had several seizures, your brain becomes primed to have seizures at a lower threshold. Same concept, but it has to do with seizure threshold and not with medication. Again, the threshold is lowering instead of increasing. Here, you think about the alcoholic as a good example. They have to take more and more liquor in order to have an effect. With the sensitization, the opposite effect is happening. Less and less of the substance will have the same effect. So, it's important to talk about those effects both at the site of action and in a net negative sense. Drugs are typically characterized by their ultimate impact on the endogenous chemical process of interest, right? And so if you're interested in gamma-aminobutyric acid, you're looking at drugs that are agonists of GABA, meaning they make GABA act more strongly or more, or antagonists of GABA, meaning they make the GABA act less. But agonism and antagonism can be indirect or direct, meaning there's multiple ways this can happen. So if GABA is your chemical of interest, producing more GABA might be an agonistic effect. Producing less GABA would be an antagonistic effect. Causing GABA to transport more readily or more quickly from production site to terminal button would facilitate or be agonistic. Inhibiting transport would be antagonistic. Inhibiting release would be antagonistic. Facilitating release would be agonistic, right? So binding at the postsynaptic receptor, you facilitate binding, that's agonism. If you interfere with binding, it's antagonism. And then finally we have uptake or destruction, same concept. It's important to remember that you're interested in the effect on the chemical, not the chemical's effect on the downstream process. So for instance, GABA is an inhibitory neurotransmitter, but when you're talking about GABA agonism, you're talking about more GABA, which means more inhibition. So it may be kind of hard to keep track of. It's kind of like when you multiply -1 by -1, you get +1. This is that kind of system. Agonism we're generally talking about at the chemical level, so GABA agonism or GABA antagonism, even if the GABA agonism is an inhibitory process and the GABA antagonism is an excitatory process. The book has a great picture, gives you some examples of many different versions of this. And so you see here all along the pathway, you've got options for antagonism and agonism. And so I think in blue, the blue ones are agonists, the red ones are antagonists, right? So just to check, you've got a chemical and you do something to cause destruction of that chemical within the synapse to occur more frequently. Is that an agonist or an antagonist? That's right. Antagonist because the drug is being destroyed, meaning it's less available, right? So I always think about the ability of the drug to act on the downstream neuron. So take a look at these and remember again that this is the kind of system where there could be double negatives and things like that, triple or quadruple negatives. You have to keep track of whether the net impact of an action is excitatory or inhibitory, as well as if it's agonistic or antagonistic to the chemical. I want to mention some other concepts related to this. Again, there's direct and indirect antagonism or agonism. People also use the terms competitive and non-competitive, and these are important ideas. So an agonist is called direct when it binds with the same binding site as the endogenous chemical of interest and activates the receptor like the endogenous chemical does, right? So it's kind of a hokey example, but if you're talking about something like taking melatonin supplements, the melatonin supplements go into your bloodstream, they go into your brain as melatonin. The melatonin is obviously a melatonin agonist because it is melatonin, right? And so when it's binding at the receptor sites, it's direct, meaning it binds with the receptor site in the same way as other melatonin does, right, even though it's exogenous. It is also competitive, because if it's binding at that receptor site, then another melatonin molecule can't bind at that same receptor site at the same time. It's taking up the space and line. In contrast, there are indirect routes of agonism and antagonism where there's a facilitation, for instance, in the agonistic case, but not in a way that interferes with the principal ligand. And so, for instance, if I was measuring how many people, say I had a bunch of computers in this room, I was measuring how many people log into them, right? Well, I could directly agonize by jumping on the computer and logging in myself, right? I could indirectly agonize by holding the door open so more of you get into the room and log in yourselves. I'm not competing with you when I'm holding the door open because I'm not using a computer. But when I log into a computer, I'm competing with you because you can't log into that computer because I'm there, right? So competitive or non-competitive is another important distinction, and applies to agonism and antagonism. I don't have a picture of this in here. The book, I think, shows a great picture of how competitive and non-competitive antagonism look. So for instance, if you have a receptor and it's got a binding site for a chemical, say for serotonin, and you have something that fits in the binding site but doesn't turn the key, like if you think about having a key for a lock, except it's the right kind of key, but it's the wrong actual key, so you put it in the lock and it doesn't turn, that's what the competitive antagonist is doing. It's going in the lock, it's not turning, it's not opening the channel, but it's also preventing any other key, i.e. serotonin, from going into that same lock. I want to talk at least briefly about the major neurotransmitters, and we'll talk in more detail on an ongoing basis about these. As I've already mentioned, glutamate and GABA are very important. Glutamate is an excitatory neurotransmitter. In the efferents, it's acetylcholine, but in the central nervous, in the brain, it's glutamate. GABA is the primary inhibitory neurotransmitter. And essentially every neuron in the brain has some kind of glutamate GABA process. Your actual cognitive processes are primarily GABA and glutamate processes that are modulated by the other neurotransmitters. So, as I mentioned, glutamate is what is the primary excitatory neurotransmitter. And it's an amino acid. It has 4 different receptors, 3 ionotropic, fast, local effect, 1 metabotropic, diffuse, slow effect. And the 3 ionotropic receptors, there's an AMPA and a kainate one. The AMPA and the kainate ones are straightforward sodium channels that are opened by glutamate. The N-methyl D-aspartame receptor is a complex channel that does a few things that the book talks about more. It lets both sodium and calcium into the cell, and it requires both glutamate and glycine to open. And the calcium channel function is very important, particularly in terms of potentiation or cell modification based on experience. So there is a metabotropic receptor for glutamate also that allows for modulation over time. Here's a picture of what glutamate channels look like. And so for instance, the NMDA receptor has the glutamate and then it requires the glycine binding to open. GABA is inhibitory neurotransmitter. It's chemically related to glutamate by a carboxyl group, so it's also an amino acid derivative. And it's the principal inhibitory neurotransmitter in the central nervous system. There are 2 receptor types, GABA A and GABA B. The A receptors are ionotropic chlorine channels, and the B receptors are metabotropic potassium channels. And just as some examples, barbiturates and benzodiazepines like Xanax are non-competitive again, meaning that they don't interfere with the direct action of GABA A agonists, and baclofen is a common GABA B agonist. So barbiturates are used for a few things. They can be used for severe seizures, as can benzodiazepines. These are primarily used at this point for anxiety. Prescription barbiturates, nasty drugs, not so common anymore. Benzodiazepines are in very common use. And then baclofen is most commonly used to manage spasticity. And so we haven't really talked about the motor tracts yet, but in your motor system, if any of you have, particularly if you've worked in a spinal cord injury setting, if you have a if you have a lesion that preserves the spinal regulation of nerve but doesn't allow for control or inhibition from the brain, then you will have a spastic effect. You have a different effect if it's an upper motor neuron lesion. And so you see this in spinal injuries, but you see something else, for instance, in ALS. Spastic means the muscles are spasming, right? Baclofen is often used to manage that. So people with spinal cord injuries will sometimes take oral baclofen. Sometimes they'll get a pump implanted. It's used in some other things that affect the spinal cord, sometimes in MS patients as well. So they do these procedures in most of the local hospitals, like it's at St. Mary's, and so when I was at Mary Free Bed, it was common to have patients that were getting baclofen pumps put in, and they can help out a lot often. And then again, so that's a GABA B or metabotropic agonist. Acetylcholine is the primary efferent excitatory neurotransmitter, and so muscular movement is accomplished by acetylcholine action. It's really well studied because it's prominent in the peripheral nervous system, and it's a lot easier to see chemicals that are outside of the brain. And it also functions as a general facilitatory neuromodulator inside the brain. Meaning, outside of the brain, it's a primary excitatory neurotransmitter and has a modulating role inside the brain. And so there are systems originating from the dorsolateral pons that handle REM sleep, for instance, in the basal forebrain and the medial septum. And this one is associated with learning, they're both essentially associated with learning by facilitating the cortex and the hippocampus. And remember, both these structures are important in learning. There are two kinds of receptors for acetylcholine. There's an ionotropic receptor that is stimulated by nicotine, and is particularly important in triggering of muscles. It's blocked by curare, and it does have an axoaxonic presynaptic facilitation process, and that can lead to addiction. That's probably what's responsible for nicotine addiction. And there are metabotropic or muscarinic receptors that are blocked by atropine. And so these drugs are particularly important in terms of their historical relevance, because these drugs were nicotine, muscarine, curare, and atropine were all really important in understanding how acetylcholine neurons work. And in the central nervous system, they're mostly metabotropic, neuromodulating. And neuromodulating is a slow process that affects many places. Metabotropic processes are slow and they affect many places. So you're going to see muscarinic receptors in the brain more than ionotropic receptors. Here are examples of some things that happen in the acetylcholine process. And so to make acetylcholine, there's a choline acetyltransferase, or CHAT, that binds choline with part of this coenzyme and creates acetylcholine. And then acetylcholine esterase, the esterase part is the scissors. Acetylcholine esterase removes that. So this acetate ion ultimately makes its way back to acetyl-CoA. And so the process is regenerative, right? Like these acetate ions don't go away, they get used again, and go through the CHAT process again. And this allows the body to up and down regulate choline, right? Upregulate, meaning creation, meaning allowing for more acetylcholine to be present. Downregulation, meaning getting rid of acetylcholine. We talked about the monoamines. The monoamines have a lot of interest in psychiatric conditions, and they've been very heavily studied in psychiatric conditions, particularly dopamine, norepinephrine, and serotonin. Monoamines come in two chemical classes, catecholamines which in particular include dopamine and norepinephrine, and indolamines, which particularly include serotonin. Melatonin is also an indolamine. And so these are chemically different, and there's a common pathway for production of these ones, but serotonin is a different precursor, tryptophan. I showed you this picture before. So here again is graphically what this all looks like. You see these different locations. As a general principle, all four of these chemicals in the brain are produced in certain pump areas and distributed broadly throughout the brain, as opposed to, it would be useful to show this map for GABA or glutamate, because GABA and glutamate producing neurons are everywhere in the brain. They're not pumped from central locations. So dopamine. There are three important dopaminergic pathways: the nigrostriatal, mesolimbic, and mesocortical. The nigrostriatal pathway projects to the basal ganglia and affects control of movement. So this pathway is particularly important in Parkinson's. I showed you the picture last week of the depigmentation of the substantia nigra basal dopamine neurons. Mesolimbic, in particular, is important in schizophrenia. It projects to the limbic system and affects learning and motivation. Mesocortical is possibly also relevant to schizophrenia. And there's actually some interesting ideas that in schizophrenia, so originally we thought of schizophrenia as a too much dopamine disease, in contrast to Parkinson's, which was a not enough dopamine disease. And what's consistent with that is that if you put too much dopamine in a Parkinson's patient, they'll start having psychosis. And if you block dopamine too heavily in schizophrenia patient, they'll start having movement disorder symptoms like tardive dyskinesia. Right? So that fits the model. Interestingly, with these two, what it looks like is that schizophrenia, some people think, may possibly be too much dopamine in this system, the mesolimbic system, causing the psychosis, too little dopamine in the mesocortical system causing the thought disorder. And so in order to treat both of those, you may actually need something that allows for less dopamine in one place essentially and more dopamine in another, or more dopamine effect in one place and less in another. That's something we're still understanding better as we continue to understand all of this. Some people think that the schizophrenia is better explained as being the dopamine excess component, and then also some kind of structural brain degeneration that affects some of that explains the negative symptoms and why the negative symptoms don't respond to treatment. Dopamine receptors appear to be metabotropic, all of them, and that fits with the idea that dopamine's a modulator. It's not really involved in exciting or inhibiting directly. But some are postsynaptic like D1 receptors, and some of them are pre and postsynaptic like D2 receptors. And that potentially fits with what we know about D2 being important in schizophrenia. The presynaptic D2 receptors may be really important for the learned component, not necessarily meaning you chose to become schizophrenic, why not, but more meaning that there's a development of the symptoms over time as the brain learns. So again, dopamine is derived from tyrosine through an enzymatic process, and norepinephrine derives from dopamine via that same process. We mentioned earlier that some of these precursors like L-DOPA can enter the brain, but dopamine cannot. And so you can't just put dopamine in a pill to solve Parkinson's. You have to put a precursor in a pill. Norepinephrine, which derives from dopamine, is important as a neurotransmitter. It's also important as a hormone. And so the book talks about epinephrine and adrenaline being the same drug, right? And so it's called norepinephrine because it opposes adrenaline, sometimes also called noradrenaline. And in fact, the term noradrenergic and adrenergic are fairly commonly used. Epiphrenergic or epiphronic or whatever, not so commonly used. So you should know both of those terms. But it is also important as the opponent to adrenaline. And that's important. You can pretty easily remember what adrenaline does in terms of its excitatory sympathetic activity. And norepinephrine is the opponent to that in the peripheral nervous system. In the brain, there are several structures that are in the pons, the medulla, and the thalamus that produce norepinephrine. And it's particularly important as a source of vigilance, particularly from the pons, from the locus coeruleus. Most norepinephrine receptors are also receptive to adrenaline, and so oftentimes the term adrenergic receptors are used because they respond to adrenaline and noradrenaline, and so they're alpha and beta adrenergic receptors. And drugs that affect these are really common, particularly for antihypertensives. So for instance, I think clonidine is an alpha-2 adrenergic agonist. And this kind of also tells you why some of those drugs have psychopharmacological effects. Many antihypertensives improve focus, reduce problem behaviors, and so forth. And so it's not uncommon to see kids with ADHD on guanfacine, which is an antihypertensive, as an adjunctive. It's approved for that purpose. Clonidine is used in kids with a variety of behavior disturbances. Clonidine and propranolol are used in autism sometimes as a low-risk way of dealing with behavior because these have peripheral and central nervous system effects. You want to think about those in balance. It is an antihypertensive. You don't give it to a kid who has low blood pressure already in order to solve the behavior problem. You create a new problem. Serotonin is not derived from dopamine and norepinephrine. It's derived from a different chemical, tryptophan, different amino acid. There are 9 sources in the midbrain, pons and medulla. The most important of those are the dorsal and medial raphe nuclei. And so the dorsal raphe nucleus, you should remember that, is an important source of serotonin. There are many different receptor types, although a lot of research has gone into the 5-HT1A and 2A receptors, and their role particularly in understanding how selective serotonin reuptake inhibitors work. So here, tryptophan, ultimate derivative of serotonin. I don't know if the book talks about it, but my understanding is because of the blood-brain barrier, the idea that this is the explanation for getting sleepy after you eat turkey is actually a kind of a urban legend. But tryptophan is the source of serotonin. Serotonin is transported like any other neurotransmitter. I want to mention briefly the serotonin transporter if you haven't already heard of it, because it does receive a lot of attention in neurobiology. So the serotonin transporter molecule has this long abbreviation 5-HT-TLPR, which sounds almost like it may have to do with the World Wide Web instead of with the brain, but the 5-HT-TLPR has a long and a short variant. And the long allele is generally associated with better management of the stress system. And so there are lots of positive effects that are typically attributed to L and negative effects that are attributed to S. And so you have 2 genes that code for an L or an S, and so you can have 2 L's, 2 S's, an L and an S. And so, especially when the S is homozygous, there is often poor outcomes associated with that. And those outcomes are associated with a wide number of diseases because of the central role of the stress mechanism. And so you'll see research into outcomes after cancers, outcomes after bodily injuries like fractures and other things, as well as response to antidepressant medications. And some studies suggest that at least some of this may be race-mediated. And so, for instance, there's some studies that suggest that the L allele is associated with more positive response to antidepressants that are SSRIs. But at least one meta-analysis suggests that when you look at Caucasians and East Asians separately, the effect exists for Caucasians and not for East Asians. The others don't really explain why that is, but they hypothesize that that for whatever reason, depression is more stress-mediated in this population. I don't know, maybe not. Male gender and younger age are also mediators of the serotonin transporter effect. And again, so men will respond to this better than women, and younger people better than older people. There may be kind of a general pattern there. In my clinic today, we actually talked about a paper that suggested that the same effects seem to happen in kids with autism who are given SSRIs, even though autism is a different neurochemical process or neurodevelopmental process than depression. There's sometimes when you look at diseases that have gender or sex effects, like diseases that are more impacted with men and women, there are often variables that you can use to remove or account for the gender imbalance. For instance, there's a gender imbalance in autism on one end of the autism spectrum, but as you move to higher and higher functioning, you see more and more women, and so the ratio corrects towards equality. There's some arguments that certain kinds of depression are more, that effect explain why women get more depressed than men. And there are probably kinds of depression that are less stress mediated that explain the difference between men and women. So when you remove those non-stress mediated causes of depression, which occur less often in men, then you see a stronger effect of the serotonin transport protein. So there may be a general story there that we're still learning. I want to mention briefly that monoamine oxidase is a common mechanism to render monoamines inert. And so here's a picture of how that works with dopamine. See the dopamine molecule, the monoamine oxidase inactivates it. There are monoamine oxidase inhibitors or MAO inhibitors. That was an early line of antidepressants, and they're still used for other things. And so MAO inhibitors block this process. I want to talk in this section about peptide neurotransmitters also. There's a lot of really interesting stuff when you get into these other less common neurotransmitters. We'll be talking about them as we look at different functions. For instance, we'll be talking about some like neural peptide Y and orexin when we talk about eating and sleeping. And so some of these may really hold interesting components of the story with specific behaviors. And so there are a number of peptide molecules that are active in the CNS. They're typically active both as neurotransmitters in the synapse and also as modulatory chemicals outside of the terminal button, outside of the synapse. So the terminal button, again, remember, it sits on the synapse like this. You can release chemicals here. You can also release chemicals on other surfaces of the terminal button. Those are going to go into intracellular fluid. When stuff goes into intracellular fluid, it acts as a neuromodulator. It has a broader effect. It works in more places at once because it's not just going into that synapse. The opioids are one important class of peptide neurotransmitters. And so this is one you probably have heard of. The most common thing that they do is the analgesia, the pain killing. They also do some other things like inhibit species-typical defense mechanisms and potentiate reward systems, meaning they have a positive effect on reward, which makes them very prone to addiction, right? Although this varies in people. If you've seen stuff about the opioids, there's lots of interesting things about them. In the past few years, there have been repeated studies that suggest that there's a very large variability from person to person in how effective opioids are in your body, by as much as a factor of 10, which is a really large difference between one person and another. You think about needing 10 times as much of a drug as someone else. You may, probably many of you have taken a narcotic chemical at one point or another, you may have had this experience. There's some of us, the doctor gives you a narcotic, and after you have your teeth taken out or your wisdom tooth taken out or something, you take it, you're like, oh, this feels great. And you have a really strong benefit from it. Other people like me had my wisdom teeth removed, I got the narcotic, I took one, I'm like, doesn't really seem to do anything. I put the rest on top of my dresser and forgot I owned them. There's a really big difference, and that's gonna play a role in addiction, but also in terms of medication effectiveness. You think about it, suppose I am one of those people who has a low response to narcotics. If I really need them, that's a problem because we talked about this dose-response curve and the safety margin, right? If I need a high dose for efficacy, I have a low safety margin, meaning the dose I need to be efficacious is going to be very close to the dose that's toxic for me. So that's a potential problem with opioids for people who are not responsive to them. Opioid direct agonists are used as analgesics, you probably already know, like codeine and so forth. Opioid antagonists, like naloxone, are also important. They can be used to reverse intoxication, so sometimes they're used acutely to deal with the effects of overdose, for instance, heroin overdose. there's an important concept of complementarity, meaning many times a peptide neurotransmitter will have an effect in the brain, and then a peptide as a hormone will have an analogous function outside of the brain, in the endocrine world. And angiotensin is a good example. Have you ever heard of an ACE inhibitor? That's a kind of cardiovascular drug, ACE angiotensin converting enzyme. And so angiotensin, outside the brain, what it does is it adjusts the kidneys to deal with low fluid levels if fluid's unavailable. Right, and so this is a sensible thing to do. You don't want your kidneys to dump out all your liquids if you don't have an opportunity to get more liquids, right? Inside the brain, it has a complementary effect. It stimulates thirst. You don't have enough liquids in your brain. In your body, what should you do? You should drink, right? And so your brain, inside your brain, ACE will stimulate thirst, angiotensin will stimulate thirst. Outside the brain, it will prep the body to deal with the absence of liquids. So that's what I mean by complementarity. These two functions achieve similar goals. Lipid-derived chemicals can also transmit messages between cells. So they're the endocannabinoids. And there are two metabotropic receptors, CB1 and 2, that are common throughout the brain. We knew for a long time that cannabis or marijuana affected these. It took a while to find anandamide, which was an endocannabinoid, meaning anandamide is naturally produced in the body. If these receptors are here, they must be doing something. The mystery was what they were doing, because they were probably not there purely just for marijuana, because marijuana is not used by that many people in a broad sense. It's not like something 100% of the population uses. Like you would expect your body to have receptors for sugar, which you do on your tongue, because everybody consumes sugar. Not everyone consumes marijuana, and so you wouldn't expect there to be a receptor purely for that purpose. Anandamide turned out to be the endogenous chemical. Acetaminophen is actually also a CB1 agonist, same receptor. Although I think it's pretty hard to get high on acetaminophen. So try. As mentioned previously, variants of adenosine and other nucleosides are active in the intracellular communication, protected by the purinergic signaling with ATP, and then nitric oxide, which is a gas, appears to play a role in learning through cell modification, even though it's a really simple chemical compared to the peptides. This gas plays this role that has to do with the change of cells in response to intracellular processes. And so here what's happening is you got a glutamate neurotransmitter, puts glutamate into a synapse, and that glutamate is taken up by this downstream neuron, right? In that process, probably through these N-methyl D-aspartame receptors, the stimulation of nitrous oxide leaves the body through the membrane. It goes into this GABA interneuron, this GABA neuron, and then it modifies this GABA process. And that can lead to things like changing the receptor density. The number of these receptors on the cell surface is variable over time, so it can stimulate more or less of those and change other things like that. And in long-term potentiation, then that can cause a blurring process. We're talking about experimental methods next. The way the book presents this chapter is really in the context of experimental methods, right? Like how can you learn the science of the brain? I revealed my bias. I am a clinician by my primary role, and so I am very interested in what you can do with this information to help people. And so I do want to expand this a little bit and talk about these tools, not just as tools for understanding how the brain works in a general sense, but tools for understanding the specifics of a person's brain in a healthcare kind of context. And so I'm going to talk about some of these tools in their clinical utility as well as their experimental utility. So it'll be a little different from what the book does in this regard as well. Okay, so the lesional model is a really important model to understand in experimental methods. It is a classic in explaining psychological functions. You go back to Broca and Wernicke, these two situations that were lesionally based, right? Like the brain tumor and the gunshot injury. these are models that explain that a structure was necessary or sufficient for a function. Meaning, for instance, that Broca's patient didn't have a productive speech area and he couldn't talk. Wernicke's patient didn't have a receptive speech area and couldn't understand, right? And so in this case, for instance, really good productive speech required both Broca's and Wernicke's areas, because the Wernicke aphasia patient has kind of nonsensical productive speech, although the gross impairment is in the receptive speech. But, so Broca's area was essentially necessary, but you needed both of them for it to be sufficient, right? So another example of that we mentioned really briefly, we'll talk more about when we talk about memory, is there are two memory pathways. There's a pathway that's called the PAPEZ or PAPE circuit, P-A-P-E-Z. There's some disagreement on how to pronounce it. The PAPE circuit involves the hippocampus and the cingulate gyrus and the prefrontal cortex. And there's another pathway that involves the amygdala, it's sometimes called the lateral limbic circuit. It involves the ventromedial or orbitofrontal cortex. It involves the uncus and some other structures. They involve different parts of the thalamus. It is sufficient to have one of these, and you will still have some memory, although it's best to have them both. HM, the famous seizure patient, he had a profound loss of new memory formation because he lost both pathways, because amygdalocampectomy removed both of his hippocampuses, both of his amygdalas, and some related tissue that prevented both of these circuits from working. So it's important to understand that you can learn a lot about how structures work based on lesions to those structures. Although in doing so, you have to remember the structures may be necessary, they may or may not be sufficient for a function. It's also important to differentiate that developmental and acquired impacts of a lesion are very different. We talked about alexia with autographia briefly in prior lecture. This is the neurological disorder where you can write but you cannot read. And it's important to note that a acquired lesion of the corpus callosum and related structures can cause that kind of syndrome. But we also talked about agenesis of the corpus callosum or dysgenesis of the corpus callosum, which is a developmental variant where the corpus callosum never formed in that area. There will be compensation, so those patients typically won't show a symptom like that. So developmental lesions work differently than acquired lesions. Sometimes having an early developmental lesion is a big problem because it prevents the developmental process from occurring later. Other times, the lesion precedes the development and the brain is able to compensate during the developmental phase. So there are some rare examples of kids who have extreme brain abnormalities, like a kid who had half of their cortex removed, like one hemisphere, and who is largely normal in many ways because it was a developmental insult and not an acquired insult. Whereas the acquired person would have profound hemiparesis and all kinds of other stuff. In the lesional model in animals, highly precise lesions can be used, creating things like using things like varnished electrodes. So you take a little thin wire, you put varnish that prevents it from conducting around everything but the tip, right? You pass it into the brain tissue. You can put it there inside the brain, and then you can have this tip that just might be on the micron kind of size scale, and you electrify it, and then you cause this little tiny lesion, and so you can be very, very accurate. The book talks about, though, that you do need to do postmortems on the animals to make sure the lesion was in the place you thought it was, because sometimes it'll turn out to have been somewhere else. So I think they choose this example of an animal model study where one of the animals didn't fit the expected pattern, and it turned out later when they examined that brain, that was because the lesion was in the wrong place. The other thing is that there is tissue damage associated with pushing this biopsy needle or this electrode down into the brain, right? And it's a significant procedure. It might have some other kind of psychosocial kind of impact on the animal, right? So you do need to have a sham lesion procedure. You need to approximate the procedure in such a way that you know that it is this lesion that the electrification caused that's causing your effect and not something else. And there is another more advanced genetic model, or another different genetic model, that can also be used in conjunction, which is this gene replacement process. And I want to mention that at least in passing. Here's a borrowed slide from a lab that does gene replacement therapies. There's a lot of active work going on in this area. And so you can identify a mutation that codes for a protein of interest, and you can insert in the embryo in such a way that you will create a process where some of the cells, because this is an embryo, it has multiple cells that won't affect every single one, some of the cells in this chimera will have the desired altered genetic sequence, and then the mature chimera can reproduce. You make the mature chimera. The chimera here just means that the animal has both kinds of DNA. Some cells have one and some cells have the other. You make the chimera with a normal mouse, a wild type, or from a specific family of mice that is genetically known. And over time, with the mating, you can produce a family of mice that, for instance, have a homozygous knockout, which means that the knockout will have to be effective since both proteins are knockout variants. And by knockout, I mean this gene codes in such a way that the protein isn't created or isn't effective. Then there's an even fancier variant of this, let me mention briefly. Some of these knockouts can be turned on and off by other processes, and so you can create a mouse where you create a gene that can be activated, meaning you can develop the mouse with or without the presence of the protein and then turn it on or off later. So you can do some pretty cool stuff, essentially. And you can do some really great things. Like you can demonstrate, for instance, that there are certain proteins that code for features that will enable are sufficient or necessary for the addiction process, for instance. If you knock them out, the mouse will no longer show chemical addiction to that substance. You can then restore them, like with a chemical that, like you can give them a drug that replaces the protein that's not being made because of the knockout, and then the addiction behaviors will return. And so you can demonstrate really clearly that this protein process at the gene level is responsible for the behavioral outcome in the mouse. And then, perhaps someday you could develop gene-oriented therapies for adults or for humans as well. But this is a really interesting thing from a research standpoint. I do want to mention really briefly that RTMS, or transcranial magnetic stimulation, is really interesting in this context. It is sometimes called the reversible lesion. So RTMS uses this magnetic coil. You pass electrical currents, that creates a magnetic field, right? The magnetic field, if it's going through here and here, the effect out here will be that it'll be moving in this direction or this direction behind the coil. And so you can generate a magnetic field inside the brain tissue. It has limited depth penetration in most models, although there are some coil technologies that will improve that for deeper penetration. So most of this is for cortical structures right on the surface. And so what you do is you can sometimes stimulate structures, but of particular interest is that repetitive bursts, or RTMS, can be used to render a brain structure inoperative. And you can actually render the brain structure inoperative for about an hour. And so you create a lesion that goes away, right? You're not brain damaging this individual, it's safe, but temporarily you can turn cortex off. So you can do some interesting things, like you can, boring interesting things, like you can use the coil to simulate a particular motor cortex area, which will cause like your finger to move or something like that. It's interesting because it looks cool. It's boring because you already knew that that motor cortex did that. Not a big surprise. There is some interest in using these deep penetrating versions to affect things like depression, and so people are interested in this as a potential treatment modality as well. But in particular, if you can identify a structure and you can reach it with the RTMS, you can demonstrate, much like in the mouse model, that that structure is either necessary or sufficient for a cognitive process. I'd like to review imaging again with some additional emphasis on human imaging, both for neuroscience and clinical use. I want to draw your attention to a distinction that's fairly important between structural and functional imaging. we've talked about this idea of structure and function already. In the context of imaging, structural imaging is imaging that tells you what the composition of the brain looks like. Functional imaging is imaging that tells you about processes in the brain and whether they're operating in a normal or abnormal way. So, some structural imaging techniques, computed tomography or computed axial tomography, like a CAT or CT scan, bedrock of clinical brain imaging. It's a series of X-ray scans that are numerically computed, reconstituted into a three-dimensional image. And you'll see this, essentially in any hospital you go to anywhere. For some basic reasons, it's fast and cheap. It's very good at showing intracranial bleeding. And these two properties in conjunction are really good, particularly for strokes and TBIs, because you don't want to screw around with a long, slow imaging process when you're trying to figure out if a person has a large bleed in their brain. You want to find out quickly and then move on to intervention. And so, for instance, if a person has a hemorrhagic infarction or has a large bleed that is compressing the brain, you want to know about it so you can do something about it. You can follow up with a more detailed imaging technique later. So it's a standard of care for acute management of head injuries, for instance. The major cons for CT, the biggest one is that it's a low resolution technique. It doesn't show you brain structures in great detail. So it's not going to be good for looking at fine abnormalities. The other thing to consider is that a CT scan, because it works with X-rays, it does use ionizing radiation, meaning actuarially there is some additional risk. What I mean by that is, if you get a CT scan, that doesn't mean that you are going to get cancer. It doesn't work that way. But for every 10,000 of you that undergo an additional CT scan a year, it may be that one of you gets some kind of cancer, for instance. That's what I mean by the actuarial risk. Like another context in which we talk about this or don't talk about it is the TSA changes with airline regulations, like a few years ago, right? So when TSA went to these high-tech imaging techniques, they went to two imaging techniques, the millimeter wave and the backscatter X-ray technique. So the backscatter X-ray technique does use ionizing radiation. It's not going to necessarily give you cancer, but in an actuarial sense, there are millions and millions of people who pass through these scanners every day. There are going to be additional cancer mortality cases that are associated with these scanners. This is a fact of life. And we have to balance the fact that we may be stopping terrorists in this case with the fact that there will be some people who die as a result of the imaging technique. Not very many, but still, it's actuarial, meaning you don't know who they are, unfortunately. You probably would have a different opinion if it turned out it was your brother who was the person who would die as a result. So something to think about. And so, in particular, in a clinical context, I don't mean to be political, but in a clinical context, what you want to think about is if you want to do repeated imaging, you would like to avoid doing the imaging over and over again with CT scans because you are adding to the X-ray dosage every time you do it, even if it's a small addition. And it is important to understand also that there are lots of other sources of ionizing radiation. Like you get exposed to a fairly large amount of it every time you go on a flight, particularly an intercontinental flight. So it's not the only source, but it is a risk. Here are some examples of CT scans. And you can see kind of, this is a CT scan and this is a brain MRI. And that's why I'm showing you these together. So they're kind of the same region, but what I want to draw your attention to is the difference in the level of detail between the two images. It's pretty typical. So you can see here how the MRI shows you a lot more detail than the CT. But the CT, again, very good at showing blood products where they don't belong, or liquid where it doesn't belong. So it's very good for acute management of issues. The other thing to think about is that MRIs are magnetic in nature, right? And so if you do have ferromagnetic materials in your body, then you may not be safe to undergo an MRI. And so that could include people who have old implants that are ferromagnetic, could be people who have some kind of shrapnel from an injury. Some of the less thought about causes would be like people who work in an industrial environment, like around mills or things like that. They may have metal shavings, like they may have gotten into their eye or something like that, so they may have some ferromagnetic material you don't know about. These magnets are pretty strong. Some of the magnets can take that metal shaving and pull it through your skin, right? You don't really want that. And so you do need to know if you have magnetic substances in your body. Enhancement is an important concept in the context of imaging. So imaging utility can be extended by injecting an agent like gadolinium that has some kind of differential effect. That's really the core here. That is, what you want this drug to do is to make certain kinds of structures of interest easier to see, right? So a real common example is that there are certain kinds of brain tumors that will take up certain kinds of enhancing agents. And here's a picture of that. And so like, I think this is called a ring enhancement. And so this lesion, if you inject contrast, you'll see really clearly that it is a brain tumor and not some other kind of structure. So that can be really useful. And it can be really useful in differential diagnosis, meaning you know that there's something there that doesn't belong, but you don't know what it is. Is it a brain tumor? Is it a cyst full of liquid? Is it blood? You can tell in a number of different ways. Contrast is one that helps with some of that. And contrast can be used for MRIs and CTs in particular. So MRI, magnetic resonance imaging, it's based on essentially on spin alignment. So spin is a quantum mechanical property of matter. If you think about a ball rotating, it has angular momentum, meaning it's spinning around. If you think about that ball getting smaller and smaller, it continues to spin around. An electron doesn't have any physical size, there's nothing spinning, but it still has a property that has that same kind of effect of angular momentum, and that property is called spin. And it's that spin that's crucial for making MRI work. And basically what MRI looks at is how molecules spin in alignment with a magnetic field and then how they relax away from alignment. The fields are moderately strong, 1.5 to 3 Teslas in human MRIs. It's hard to make a magnet, a physical magnet, that produces a field much larger than about 10 Tesla. You need superconducting magnets very near absolute zero to get those kinds of high magnetic fields. In context, you can produce much, much higher magnetic fields in other ways, but you can't do them with solid state hardware, and so they're really limiting. You can't use them for this kind of context. Particularly with higher Tesla, higher magnetic field ratings, you get a high resolution, higher than CT in any event. You get good imaging of brain structures, and so it's a standard of care when you're looking at the details of brain structures. For instance, in MS, there's white matter degeneration. There's some characteristic ways in which the white matter changes look in MS. You can see this fairly clearly on a brain MRI. In epilepsy, for instance, temporal lobar epilepsy has mesial temporal sclerosis. This is essentially a sclerosis or scarring of the hippocampus, and you can image that in an MRI. If you remember how big the hippocampus is and you remember the CT scan, you're not going to get a good picture of that with a CT. You need the MRI for that. There are also some tricks that you can do with an MRI that allow you to get additional data. T1 and T2 in this, I think, are probably outside the scope of this class, but they have to do with what aspect of relaxation of the electron spin that you're measuring. And so, as it turns out, T1 is very good for visualizing gray matter, like the cell bodies, and T2 is very good for visualizing white matter, like the axons. And so, for instance, if you are looking for white matter disease like an MS, the T2 imaging is really helpful. And it's easy to do both of these together also. So you can see, again, kind of consistent results across the tests. The negatives of MRIs: they're slow, they're expensive, not hugely expensive. I mean, this is still something that's commonly available, but it's usually not indicated, for instance, in the acute phase of a TBI when you've got other things to worry about. You want to do this in medically stable patients, generally speaking. The patient has to be still for an extended period of time, and so some certain populations, like lower functioning kids or adults, may need to be sedated to be able to get an MRI safely. And then you're talking about a non-zero risk kind of situation. There's always some small risk associated with putting a person out, whereas just putting a person in an MRI is pretty harmless, especially because there's no ionizing radiation in this case. It's also contraindicated in patients who have significant impact, led to ferromagnetics, as I mentioned. But so there's some pros and cons. For instance, you might think, in particularly in vulnerable populations, you might think about the X-rays and choose the MRI, like for a pregnant mother or something like that. On the other hand, there may be some cases where you choose the CT because of the metal or something like that. Most clinical MRIs function at 3 Teslas, that's the magnetic field strength. That's still not good enough for certain structures. And so this paper by Wada looks at hippocampal imaging. And here, just for reference, they're comparing the cell-stained hippocampus, like in the Brain Atlas, to the brain MRI hippocampus. And so you see this structure here is this, it's kind of the same structure as this. So it's sort of like, it's kind of like comparing your Xbox 360 to like the Atari 2600 or something like that. The imaging quality over here is just not great. And so you really are not seeing the fine-grained detail, right? And so if you're looking for subtle changes, the hippocampus, particularly like in Alzheimer's or temporal lobe epilepsy, it's not really giving you the information you need at 3 Tesla, and it's definitely not going to give you it at 1.5 Tesla. There are higher field devices. There needs to be extensive safety testing for them, although they probably are safe. And then the other big problem is that they do almost invariably involve superconducting magnets that produce the high field strengths because they don't have loss, essentially, due to conduction inefficiency. But that means those magnets typically have to be very cold, like in the Magneto Encephalography, and so you need liquid helium cooling or something like that. It makes the whole thing a lot more complicated and expensive. Here's an example of high field MRI for a monkey brain, looking at 1.5 versus 7 Tesla. Just as an example, I showed you the CT and the 3 Tesla MRI, and you saw how big the difference was. You're talking about another sort of epochal jump from low field to high field. And you can see some things you really can't see on their MRIs. I want to talk about some sub-kinds of MRI and some more sophisticated imaging techniques. Diffusion tensor imaging, I mentioned tractography briefly, and I want to tell you a little bit more about this technique. DTI is a more sophisticated analysis of the T2 MRI data. And so remember T2, white matter, right? Again, you're looking at the white matter here. It's based on diffusion of water. And there's an important concept here called anisotropy and isotropy. So isotropic means the same in every direction. Like a hunk of rubber is isotropic generally, right? Meaning you pull it this way, you pull it that way, the strength is the same, right? If you think about some other materials, wood is a great example of an anisotropic material, right? It's much easier to break wood in some directions because of the grain than it is in others. And so wood has directions that are relevant. Like you understand how a piece of wood functions in an engineering structure, you need to understand what direction you're looking at it in. Your bones are an anisotropic material. They are not uniform in directionality. So they're designed to hold weight, being loaded in this longitudinal direction. They're not designed, if your arm isn't designed so you put it here and load up in the middle, it'll break much more easily that way. So DTI has to do with looking for substances that are, areas that are isotropic, meaning things happen equally in all different directions, and anisotropic, meaning they happen differently in different directions. So white matter is anisotropic. And the way you think about this is like a straw. So white matter has a capillary effect on water. If you think about it, it makes sense, right? Like suppose that I have this table and I drop a glass of water, a spill on it, right? The water, you can kind of imagine the water going off in every direction in this flat surface, right? Now suppose this table had a ridged surface like this, right? I pour water in it, it's going to go along the ridges much more easily than it's going to go across the ridges, right? Like if I pour water on another ridged substance, like if I grab a bundle of hair, it's got all these fibers, the water is going to travel along the fibers in a different way than it travels across the fibers, right? Same concept with the axons. There are fibers that have preferential motion of water along the direction of the axon, as opposed to in some perpendicular direction. So a voxel, which is a three-dimensional area, the pixel in 3D, has motion that's different in different directions if it's populated by axons. And so it's highly anisotropic, or meaning it's high fractional anisotropy, meaning much more of the flow is anisotropic than isotropic. So just in a really rough picture, you've got a voxel here, this cube, right? So water could be coming in or going out this surface, and this surface, and this surface, and this surface, 6 altogether, right? If water is coming in to every surface, that means that more water is in the voxel at the end than at the beginning. That means that the voxel is compressing. If water is going out in every direction, that means that the water is expanding, it's becoming less dense in the voxel, right? But if it is mostly moving this way, and these currents are stronger than these currents, that tells you that there's a preferential direction. That's the anisotropy. So DTI measures that, and because the axons have anisotropy along their direction of propagation, then you can visualize that. And so here, these graphs get kind of complicated. What the colors have to do with is different directions in space. And I think basically like this green is going to indicate that these are not only axons, but these axons are going this way. And this red indicates these are not only axons, but they're going this way, in essence. And you can go even one step further with tractography. So the diffusion tensor image tells you where white matter is highly directional. The complicating factor is that axon bundles are small in comparison to the voxel size. And so one voxel may have multiple axon bundles traveling in different directions. For instance, you can imagine a cross of axon fibers like this, right? And then you've got a problem because one anisotropy is canceling out the other anisotropy in principle. Like you could have a voxel where there are axons going this way, and axons going this way, and axons going this way. Now they cancel each other all out, and it looks like there's no anisotropy. Actually, there's only anisotropy, you're just not seeing it because you're not resolving it. So you can fix that using quantitative techniques, using fairly fancy mathematics. You can deconvolve, meaning disassemble that into the diffusion tensor, into likely pathways of water flow, which are in essence what matter tracts. This is not really a tool that's ready for clinical use. It's really mostly a scientific tool. And a great example is that one that I provided 1 or 2 weeks ago that had to do with hemispheric asymmetry and how the left and right hemisphere white matter bundles look different because of language. Now here is a picture of something like that again. There are some caveats to all of this. One major caveat is there's still some missing links in terms of if you have a white matter bundle and the anisotropy changes, what does that actually mean? Like what do all of these white matter imaging techniques mean in terms of what's going on cellularly at that place? And for instance, does white matter disease that is caused by like a physical insult to the white matter, how can you tell that apart, say, from MS, where there's an antibody process going on? How can you tell apart white matter injuries that will get better over time from ones that are stuck and will get worse over time? So there's some pieces that are missing still. But there actually, I mentioned really briefly with this, there are some kind of interesting isolated results. There's an interesting result that looks at frontal subcortical pathways that have to do with motivated behavior. And older adults who have depression with apathy and who don't respond to treatments well. And there's actually at least one study out of Japan where they didn't respond to treatment at all really well, and they were still depressed. And then they went through electroconvulsive therapy as a third-line treatment. And the ones who got better had improvements in their white matter in imaging. And it kind of fits with the model. That was never replicated, so I don't know what's going on with that study. But the process, is conceptually interesting. You see lots of older adults in particular that have watershed-based white matter changes that result in behavioral changes. I want to talk about a few functional imaging techniques. In contrast to structural imaging, the purpose of functional imaging is to see what's going on in the brain, not what the structures look like. You can think of the EEG as a really basic form of functional imaging. It's cheap, it's easy to administer, has fairly high time resolution, can be used for long-term monitoring. Like in seizure disorders, you may put an EEG on a person and have them stay in the hospital for several days, and you can continuously monitor so that when they have a seizure, you can capture it. It's also good for acute events. And signatures can be strongly diagnostic of certain diseases, certain kinds of epilepsy. Creutzfeldt-Jakob disease, which includes mad cow disease, is another good example. There are some complicating factors that have to do with electrodynamics and space charge. Because of the way electrical fields work, you don't really get spatial resolution out of an EEG, meaning those surface electrode readings don't map to a three-dimensional picture of the brain, particularly for those interior structures. So sometimes if you know what you're looking for, you can find it, but if you don't know exactly what you're looking for, it's hard to localize effects based on EEG. Here's some examples. This is temporal lobe epilepsy, and it shows how certain channels show this abnormal electrographic activity, which starts about here. And so localizing that, to some extent, you can find in many epilepsies, you can find a signature pattern. PET, positron emission tomography, is another functional imaging technique. It's based on pair elimination, so you think about matter and antimatter. When there's a matter-antimatter collision, you have two gamma rays that move in opposite directions, and because they move in opposite directions, it's a two-photon process. You have an array of imagers in a circle, for instance. If you have an imager here and it catches a gamma ray, and you have an imager here and it catches a gamma ray going in the opposite direction, it's highly likely that they came from a pair elimination. So you can eliminate a lot of noise that has to do with cosmic rays. And so you can detect the structure from which the elimination occurred. So you feed a radioligand into the body, and the most common radioligands are essentially sugars that have a radioactive molecule on them, and so they go into parts of the body that eat sugars, and then they give off gamma rays, and again, you can localize where the sugar is being taken up. And so those places where the sugar is being taken up are engaging in more metabolism than other places, meaning they're more active than other places. It is spatially resolved in 3 dimensions. It's fairly simple, but the spatial resolution is not very good. The temporal resolution is not very good. On a relatively long time scale of many minutes to hours. There's a similar technology called single photon emission computed tomography. It works on a different kind of a process, and it has some pros and cons with respect to PET. I won't go into those in too much detail. Here is an example in Alzheimer's disease. Essentially what this is showing is cerebral hypometabolism, which is not really much of a signature for Alzheimer's, but it does show the disease's course. Here's one in PET, in Parkinson's, and this one has to do with fetal dopamine administration. So this person has Parkinson's, their basal ganglia are less active than in healthy controls. They had fetal dopamine neurons implanted in their brain, and then post-imaging, post-surgical imaging shows increased basal ganglia activity, suggesting that the implanting of the dopamine neurons, remember they were in the substantia nigra, is causing the basal ganglia to become more active, which is good. Functional magnetic resolution imaging, magnetic resonance imaging. So fMRI is a functional technique, whereas MRI is a structural technique. The most common fMRI is called BOLD, or blood oxygen level dependence, and so it's essentially measuring the flow of oxygen in blood, which is again a metabolite. It's a metabolism marker, meaning when you're looking at which cells are using more of the oxygen, this tells you which parts of the brain are more active. There are also some other ways to measure fMRI. You can measure perfusion, which is blood flow. You can measure diffusion, much like in the diffusion tensor imaging. You can also do some spectroscopy. You can look for specific metabolites. As in this previous slide, this is not FDG PET. This is PET looking specifically for dopamine uptake. So you can introduce with spectroscopy. You can look for specific chemicals that are part of known processes. Better spatial resolution than PET better temporal resolution than PET, no ionizing radiation. So this is a good one. It's very common in scientific use. It's being used for some clinical work, although the real trick is in what the behavioral paradigm is, because generally speaking at this fast time scale, you're looking for how a person responds while doing something. You have to design that test really well so that you are localizing a specific brain function, because otherwise all kinds of brain structures will activate as part of the task completion and it won't tell you anything useful. Temporal resolution is faster, but it's still on the order of several seconds. And so the temporal resolution is not as fast as neurons. Remember, many neurons can fire at a kilohertz kind of timing, like 1 millisecond. So if you're imaging over several seconds, you're not measuring a process that's happening in real time. Here's an fMRI example. There's a fusiform face area that's used in facial recognition, and this is a facial recognition task with emotional faces, showing a healthy control as activation there. People with autism, even when they're solving the task, they're not using this face area, which suggests possibly some kind of deficit in facial recognition in people with autism, at least with emotions. Magneto Encephalography. Magneto Encephalography is a magnetic analog to EEG. It uses a kind of detector called a superconducting quantum interference device. Basically what that is a ring of superconducting metal that it has a very low resistance. It can measure very, very, very small magnetic fields. So the nice thing is magnetic fields are depth penetrating. They don't have the space charge effect of electric fields. And so you can measure in 3 dimensions with this, but the magnetic fields are also much smaller than the electric fields. And so you need these really high power these squid detectors to measure the magnetic field, whereas the EEG can work with a fairly low tech detector for the electric field. So you can decode all of this, and it is a complex mathematical process, into a fairly accurate spatial map with high temporal resolution. Fast enough temporal resolution that you can start to see multiple cognitive processes. And you can do some really cool things, like you can see the process of guiding attention that is an interface between structures in the back of the brain that that recognize things happening in the environment, and structures in the front of the brain that tell you where to pay attention. So you can measure things like inhibiting or guiding intention. You can also measure language processes. Like you can actually measure a process that involves communication between the receptive and expressive language areas in real time. So that's pretty neat. And there's some really interesting research going on with MEG. It is very expensive, and these devices are not in common use. There are also some potential issues that have to do with deconvolution. There are lots of statistical challenges with a lot of these techniques. They do apply to fMRI as well, and to other techniques like quantitative EEG. And so some of these issues do pose some complexities with respect to how you interpret the results. Again, meaningful results are heavily dependent on a paradigm. You have to create a paradigm that isolates the neurological process you're interested in. So here's an example, time scale of hundreds of milliseconds. Again, if we're talking about seconds for fMRI gold, too long. It's not going to capture this process. But MEG can. And here you see that it's capturing these phases potentially of language, like identifying acoustic or phonetic features and transforming them into a phonological basis, and then going from phonological definitions to lexical or meaning definitions. And so you can potentially see those in real time. And you can see different structures that are involved in these things. Briefly, let me also mention twin studies. And so there are some concepts to be aware of. Monozygotic twin studies mean that there's one zygote, like identical twins, whereas dizygotic twins don't share DNA completely. There are also some other subtleties. Identical twins can be monochorionic or dichorionic, and very rarely they can be monoamniotic. And so these have to do with the similarity of the prenatal environment. Then finally, they can be raised apart or raised together. And so you can use these things to tease out the roles of even prenatal and postnatal environment from biology. And so, for instance, with twins raised apart and together, you can see whether it's nature or nurture to some extent that's causing an effect. Important thing to remember here is that many environmental factors are actually gene-environment interactions. And so if you think of environmental factors as being purely environmental, it may seem like genes play a smaller role in behavior or disease heritability or things like that. Part of the reason for that is the epigenetic effect, and many of these gene effects are happening indirectly in conjunction with the environment.